Good morning. I'll be doing a paper presentation on does FLACS have a role in revolutionizing cataract surgery? With technological advancement, we know that cataract surgery has now shifted from visual rehabilitation to more of a refractive surgery, and it allows surgeons to customize their techniques, reducing phaco energy and duration, making it more safe and efficient. Since phaco energy is the main culprit for surgically induced trauma to the anterior segment, it leads to endothelial cell loss, affecting immediate post-op outcome. Then femtosecond laser FLACS came into play. It was originally introduced for corneal surgeries in 2001, and since 2011 it has been used for cataract surgery. It uses neodymium glass with near infrared wavelength of 153 nanometer, which focuses light on pinpoint accuracy up to the scale of nanometers. It produces ultra-short pulses in the range of 10 to the power minus 15 seconds, which limits energy requirements. The earlier studies have not correlated effective phaco time, ultrasound energy, and visual acuity simultaneously. The main aim was to compare ultrasonic energy and effective phaco time in FLACS and conventional phaco with 2.8 mm incision in grade 3 nuclear sclerosis. We also compared visual acuity in both the groups on day 1 and day 7. We had 100 patients, 100 eyes, 15 each group, and was studied for 18 months duration. Clearance was taken from the ethical committee. The inclusion criteria was age 50 and above, grade 3 nuclear sclerosis, dilated pupil, that is the pupil size more than 6 mm, and it was performed by the same surgeon using the same Stellaris PC machine. Any other patients with any other ocular pathology or complicated cases were excluded from the studies. Patients with spine and neck deformities were also excluded. Written and informed consent was taken. Patients were enrolled on the basis of inclusion and exclusion criteria. Pre-op visual acuity, anterior segment examination, fundus examination, and general examination was done. Patients were allocated into two groups using concealed allocation methods, and the procedure of surgery was the same. Intraoperatively, ultrasound energy or effective phaco time was recorded, and post-op visual acuity was recorded on day 1 and 7. These are my results. This is the comparison of ultrasound energy between FLACS and conventional phaco. The mean ultrasound energy in conventional phaco was 10.96 plus minus 4.06, which was significantly higher as compared to FLACS, which was 8.58. The effective phaco time between both the groups was also significant. The mean effective phaco time in conventional phaco was 3.21 seconds, while in FLACS it was 1.71, which was significantly lower as compared to conventional phaco. In comparison of visual acuity, there was the mean on day 1, the FLACS had better visual acuity as compared to conventional phaco. On day 7, there was no significant difference between both the groups. Several other studies have showed a similar result with possibility of zero EPT with improved surgical technique and modification. Since phacoemulsification works on piezoelectric effects, it delivers energy, facilitates emulsification and aspiration of the cataract. This delivered heat basically damages the anterior segment structure, especially the endothelium. This causes corneal edema on day 1 and reduce visual acuity. FLACS has reported to decrease cumulative dissipated energy and EPT, which is due to laser pretreatment. This laser is not absorbed by optically clear tissues, as thus the surgeon can directly remove the lens along the lines of disassembly created by laser. Another hypothesis of improved visual acuity associated with FLACS when compared to conventional phacoemulsification was due to the theoretical advantage of FLACS in creating a more precisely centered circular and reproducible anterior capsulotomy, thus resulting in a more predictable effective lens position with better IOL centration, ultimately causing improved refractive status. Summary: FLACS is one of the most debatable technological advancements in the field of cataract surgery. It is more time consuming and not cost effective in terms of equipment and low availability, but keeping aside cost factors, FLACS has a smaller learning curve, intra-op complications, and early visual rehab when compared with traditional methods. There's an incremental benefit of enhanced visual acuity on day 1, which maybe not be appreciated by the average patient. It comes into play while implanting premium IOLs or where there are complicated cases like subluxated IOL, phacomorphic or mature cataract, or patients with low endothelial count, especially Fuchs endothelial dystrophy. Thank you.
Thank you. What was the phaco surgery done? Type of phaco? Is it stop and chop or trench?
Direct chop.
Direct chop. Okay. And did you see any endothelial count difference between these two? No.
No, sir. This is another study going on in a center.
Okay, thank you.
Were the patients all comparable, like grades of cataract
Grades-
for FLACS as well as for?
So all patients were comparable in baseline parameters and all had only nucleus 3 grade sclerosis.
Even for FLACS and for
Yeah,
traditional
we took
both?
the same parameters of NS3 in both the groups.